Dr. Megan Bonanni, thank you so much for joining us. How in the world are you today?
I'm doing great, thanks. How are you?
Divine as can be, smiling and profiling. Obviously, there's a global, the world is in flux, so we're navigating the best way we possibly can and trying to share information with human beings. And it's a big part of the reason we're excited to chat with you because you're a wealth of knowledge about what's happening on the front lines in the hospital systems in rural America. So give us an idea of what your world is like right now. What's going on?
Well, right now it's actually been a little strange. We've had lowest volumes of patients we've had in years, or maybe even on record for 15 years, I think, was what I was recently quoted. But prior to this, we normally run very busy ERs, very high volumes, very sick patients, and people are scared to come to the ER right now because of COVID. So your typical ER visits have, they're really only the true emergencies or people that have no other access to medicine. A lot of medicine has moved to telehealth, which has been more successful than I think we thought it would be. And so our patients that are not as sick are very much encouraged to try and contact their primary care providers and do telehealth conferencing, again, to help prevent the spread of the disease. Our emergency departments are seeing COVID. Each of our hospitals have COVID patients. We are two COVID centers in Cadillac and in Grayling. Another center is Munson, Traverse City. And so we get all the regional cases. So if they are high suspicion or sick enough to be hospitalized, they will be transferred to our facilities for that. So I have been called up to intubate a sick COVID patient in the ICU that came from a different hospital. But our ERs right now are still, volumes are very low, nothing like what you're seeing in the inner cities.
Understood. And you said normally your hospital is jam packed. You have people probably sitting in the waiting room for some amount of time. It's not like regular illness has just disappeared. Do you think that are folks just staying at home and just getting real sick, or what does that look like? How do we take care of non-COVID patients right now?
Well, we certainly get emergency room patients that, although it may seem an emergency to them at that moment, when they reevaluate the situation, perhaps it's not. And so I think that some inappropriate ER visits have been avoided, where they are better served in our community by going directly to a dentist or directly to their primary care provider. But I worry very much about our very sick patients, specifically the elderly or the heavy smokers that we call them frequent flyers, patients we see all the time because of how sick they are. And they're not coming in as frequently for their, tune-ups, as you would say. I'm worried they're going to come in extremely ill because they are afraid to come to the hospital at all.
And I also think, do you guys deal with, kind of giving folks Suboxone or kind of ongoing medication for, drug issues and things like that? How's that population doing right now?
Well, that is an interesting population. That population comes in very frequently when they can't get access to their drugs of any sort. Generally, I'd say it's less than normal. The doctors right now, although we have so much pressure on us to not prescribe any narcotics at all, which we rarely do out of the ER for more than a few tabs. The outpatient doctors are, I think, a little more lenient than usual in just trying to keep people comfortable at home and safe at home and not have them not coming in. I think they're refilling prescriptions without, per se, that 3-month visit or some of the other recommendations that are normally in place. And there's leniency that is allowing us to not have to see those patients, which we're very appreciative of.
Understood. So you're kind of living in a bit of a ghost town right now at work. You're saying you go to the ER, it's surprisingly empty. Normally you walk in, you can see a whole bunch of people queuing to see you, and now you're waiting for the storm.
Yeah.
What are you seeing? Do you feel like you're ready? What's the staffing situation like?
Well, right now they're cutting people frequently because our volumes are so low, but having lots of people on call. So we do have plans in place. When we hit 50 COVID patients in the northern Michigan area, we switched to what we call a code orange. And that in and of itself brings in more resources available, although not necessarily at the hospital yet. So we have, instead of the ER docs intubating patients, we actually have taken the anesthesiologists who are no longer doing surgery, and there's an anesthesiology team waiting to intubate in our intubation room, which we have dedicated intubation rooms now. So they're, they are waiting to do that to get them on the ventilator, and then we continue to do the medicine and get them feeling better to the point they're stable, and then they get moved to a room. So that, along with acquiring multiple ventilators and having daily revisitation of almost all of these resources and what we can do to make it better, we're as prepared as I think we can be, but I don't think any hospital is really ever prepared for what this pandemic has brought.
Understood. And give us an idea of the quantity of PPE that you have and ventilators that you have on hand. So what size population can you serve? How hard can your community get hit before you've maxed out those resources?
Normally, we actually only have 4 ICU beds total in Grayling and 6 ICU beds total, maybe 8 in Cadillac. And so, and probably have between 6 and 10 ventilators at each hospital. Those numbers have doubled at this time. And then other hospitals that are ventilating patients prior to coming over are sending their ventilators with the patients if they have a larger resource. And I don't think it'll take much to overwhelm any small hospital system, but we have plans in place to get people transferred, to get more ventilators in, to get more providers in. In fact, our provider group, we normally don't have a physician on call. We have physician staffing 24 hours a day, and then we have APPs throughout the day. Their hours have been temporarily, they are less, but there is the possibility to expand to up to 3 times as much, and we're ready to do that at the blink of an eye. And we are all on call now. There's 24 hours a day, there's a physician or APP on call also to come in to help out. So we're ready as we can be, but I mean, we get bolus patients, we get 10 patients at a time, and they're all extremely ill. We're going to just have to take it patient by patient and do our very best to take care of all of them, as we do normally in the summer when we get, a multiple car accident, multiple trauma. We have resources that we know to call on. So in some ways, being rural, we're used to having no resources. So we are used to being creative. And I think that is a slight advantage to us for when we do get this bolus of patients.
So when you walk into work now, do you wish you were seeing tent hospital expansions built on the side just in case you do get this big surge? Is that in the deck for you right now?
They have researched it. I'm not sure what the final decisions have been. They're continuing to look at it. I know the companies have come forward and offered the tent as a resource, and the community is really coming together to help us. Any outside resources, we've had Avon, a company that does, the military grade masks, has donated a lot of these military grade masks, and they're really helping from that standpoint. I've been overwhelmed with the communities up here and their dedication to the isolation, and also then to giving us equipment. But yeah, I think that if we needed to do a tent, it would happen fast. I think it's all set up. We just haven't hit that need yet. So is it realistic, financially, or to do it preemptively? Probably not. We aren't sure where we're going to be yet. But I think that within 24 hours, it would be there.
Understood. That's really encouraging to know. It seems like you're in a particular situation where you've been blessed with an additional month to think about this issue, to read the research, to see what other places are doing, so that you guys can be really well prepared. I'm really glad to know that you feel like you're in a confident position. That's awesome.
I do.
But I know that things can change fast, and we've been hearing things on the news about splitting ventilators. Can you explain a little bit about what that is and how viable that really is?
Yeah, it certainly is, from a physics standpoint, extremely possible, and has been done before. You can take a single ventilator and you can use just, new tubing and reroute it so that you can have it actually ventilate 4 patients, sometimes even 6 patients, just from one machine. The disadvantage to that is that you can't then monitor each patient's reaction to that ventilator. You can't adjust the ventilator to each person's needs. So we're sort of assuming that we're getting similar size patients so that you have the same amount of volume. That has to be there. But the rest of it is more complex. There are minute changes that can be made on ventilators, you know, secondary to a specific patient's symptoms. So we will do it as a life-saving measure, but as a tool to really help the physician continue to monitor the patient and then make decisions based on that tool, that takes that away from us if we're using it on multiple people at once.
What are some of the different things you can do with a ventilator? Is this just a matter of changing the oxygen to air mixture? Is this pressure, or are there other things that go into the mix? What's actually coming down the tube?
Well, it's extremely complex
Okay.
because there are probably 100 different things you can do to a ventilator. The basics are that there are modes. There's assist control modes, and then there's an SIMV mode where, you know, we allow the patient to their trigger breathing and then trigger the respiration, versus the machine just does a controlled amount and then will react to a triggered ventilation. Sometimes we need to sedate them so heavily that we're completely in charge, and we then set those settings so that we're doing all the breathing for them. Sometimes it's an advantage to allow their natural physiologic response to be the driving force. It really depends on the patient. We have a specific protocol for ARDS, which is respiratory distress syndrome in adults, and this is involving being upside down, like prone on your belly on the ventilator. They're noting now that even like unbelievable amounts of resources and studies being done on all ventilator changes, but there's also pressure. So how fast that air is moving in, how much pressure is putting on the lung, and that then forces it to oxygenate at a higher or lower level. You can kind of, I guess, boss the cells around a little bit and try to push more air into them. And that's one of the concerns with diseases, that we've had to do very high pressures, which over time is hard on your lungs. You know, those high pressures on your lungs that are not physiologic, that we're creating in order to help you have that high oxygen, that can cause damage over time. And as you're saying, we had mentioned people are on vents for weeks sometimes with this disease process. So it's definitely an advantage to be able to manipulate each person's ventilator to their best suited needs with the lowest amount of pressure that we can use to successfully keep them oxygenated. They're even doing studies now about allowing patients to have low oxygen levels off of a ventilator longer than we normally would, because they're thinking that is actually safer than putting them on the ventilator with these high pressures that they're requiring. So they're doing studies on that right now. And patients that are alert and talking to you but have a lower oxygen, we're not just grabbing that tube right away, even though their oxygen's low. We're letting them kind of have a little bit of that first and see if they can bounce back before we go to that step of the ventilator. And that's been shown to be successful. But of course, all of our studies are brand new and they aren't controlled. And, you know, the research is all very, at this point, still questionable and anecdotal, but we have to use the resources that we have.
So, and we've been tracking some of this quick and dirty research, because normally you go through a multi-month, multi-year peer review process,
Yes.
but we can't afford that now. And I think that's one of the really actually encouraging things about what's happening, is that, I mean, we're cutting down a lot of bureaucracy, which is really important bureaucracy, to try to get the most up-to-date information to the folks in your community. And it's an interesting thing. Can you tell me a bit about the process that leads you to eventually put somebody on a ventilator? What percentage of the population is going to end up on a ventilator, and what things do you need to see to make that decision, and what does that process look like?
So it's very much in residency, I'm told, if you need numbers, as in like lab studies, to know when to ventilate a patient, you're not practicing medicine. So it's a very dynamic decision as to when a person needs a ventilator. There are, of course, numbers that go into your decision, but you pretty much, after practicing medicine long enough, seeing enough sick patients, you look at a patient and you know they need to be vented. They're gonna tire out. They're not hanging on. You just know. And that's supported by low oxygen levels, their increased work of breathing, you know, their pallor, the colors that they have. There are many things that kind of go into when we're going to have to ventilate the patient. I think that our community is high risk for a high number of ventilated patients because there are so many patients with COPD, congestive heart failure, and just overall coronary artery disease. And these are the highest risk populations. That is bread and butter emergency medicine. And I see that a lot up here. I would say disproportionately so to younger communities that have better access to medicine. So that particular point does worry me. that these sicker patients will come in and need to be ventilated sooner. But there is no great answer for when to ventilate a patient or how many are going to need to be vented. Hopefully isolation will be successful for some of these more high-risk patients. And so far, I have to say, it appears that it is up here.
And they have to get ventilated in the first place because COVID-19, the disease that comes from coronavirus, is essentially causing their lungs to fill up with fluids.
So, well, that's interesting. Not exactly. It's not very well understood, and there's
Okay.
still a couple of theories about why it is so difficult. It's more about, we think that it actually affects the ability of the red blood cell to carry the oxygen. So as it comes through your lungs, that's where it gets loaded up, right? Comes through your lungs to get reloaded, get all that oxygen put back onto it so it can go out to your body and get your body all the oxygen needs to continue to survive and function. And so as your numbers get lower and lower with oxygenation, the question is where is the virus attacking? Specifically the lungs, or is it attacking those cells? And they really don't have a great answer yet to that. So there are theories out there that it's actually more of a blood cell issue than it is a lung issue. But either way, there is something that the virus is doing to prevent the oxygen from coming from your lungs, your inhalation, and getting through the membranes into that red blood cell. What exactly part in that process is specifically being affected has not yet been delineated at all specifically. So we're doing everything we can to push that pressure I was talking about, to push it through that membrane into that cell. And that's why we go with the increased pressures to push it in, but we don't know where the disease in that, 15 steps is specifically attacking the body.
Understood. So what role does the CAT scan play in your assessment of what's really going on?
So a CAT scan, we're encouraged to not do them on COVID patients that are not severely ill because of from an infectious disease prevention standpoint. When we are taking a patient to another room, putting them on the CAT scan board, that room has to be terminally cleaned. We only have one CAT scan available at our facilities, so it's not like we can have one on hold and use the other one. So somebody's on a blood thinner who falls down and comes in with a stroke can't get to a CAT scan right away because it's being terminally cleaned for a patient we already know is sick and we already have a chest x-ray showing it. But if it seems disproportionate, or if we really think there's something else going on, that would be the step we would do the CAT scan on. And there are very specific CAT scan findings that correlate with COVID, and it's both sides pneumonia. It's a patchier pneumonia, not like really necessarily in one spot, or if it is like in one lobe, in a tight area in one lobe, it'll be also that way in multiple lobes. It doesn't seem to be attacking just one area and taking it down. It's taking out the whole lung, but in patchy spots. So that's what they call it patchy infiltrates. Sorry. But we're discouraged in general from doing them unless we have a very, very high index of suspicion that we have a blood clot. If for some reason they also have a pulmonary embolism or a large blood clot in their lung, we don't want to miss that because we're blaming it all on COVID. So that's sort of the clinical decision point we have to get to before we go to a CAT scan in general.
And that's what makes the intersectionality of your patient population so difficult, because you're talking about these high levels of the pre-existing conditions that exacerbate COVID-19 and making sure that some of the treatments for coronavirus COVID-19 don't put this person into a worse position. So
Correct.
how do you determine what path of treatment you're going to do based on what the intersectionality is, whether it's that COPD or high blood pressure, hypertension, maybe heart issues? What does that look like?
We're treating all of it. We're treating everything. I guess one thing we're having to decide on is whether to not use steroids in somebody who has COPD and COVID. It's sort of, as you get to the point where they're so sick, you're going to throw the kitchen sink at them. So you're going to try everything, if they're very, very ill. We're trying to tease apart the causation, what's causing the most problem, and treat that first, and then continue to treat everything else as we would. We can still treat heart disease the same, really. We can still treat, they can be on blood thinners. There's no adverse really findings or any worsening of the disease if we continue to treat the other disease processes. The only controversial part of that really would come down to steroids in somebody who has underlying asthma or underlying, asthma or COPD, and the possible worsening of COVID with steroids.
Understood. So we've been chatting about the worst case scenario, right? Having to intubate somebody, having to split a ventilator, but a majority of people aren't going to reach that stage. When you have somebody who's experiencing mild to moderate symptoms, what kind of things can you do to put them on a trajectory where they're not going to get worse, where they don't end up on a ventilator?
Well, the best thing to do really at this point is all supportive care. So if the patients are having trouble breathing, they are recommending using inhalers. As far as medications, major controversy right now. There are no great studies. I mean, the studies are with 6 patients, or, there's nothing out there that's convincing enough to tell us that there is a treatment that is really going to work. I would say the treatment for the really sick patients, going back that way, would perhaps be the convalescent IgM, which is the serum that we get from patients that have already had it. But that's the most promising long term. But short term and for not sick patients, really, is just go home do what you would normally do if you have the flu or a cold. And so symptom control is cough suppressants and decongestants, whatever makes them feel better, and isolation. And then the only real prescribed medication would be the inhaler.
But an inhaler is a steroid, is that right?
No, some inhalers have inhaled steroids in them, but the albuterol inhaler itself is just pure albuterol with no steroids in it at all.
Gotcha. Understood.
It's a beta agonist. It just opens up the lungs so that they can it makes them more flexible, I would say.
So you're working in a wartime capacity at this point. I think it's fair to say the way you guys are preparing, the PPE that you're putting off to the side, the mentality going into this whole thing, that's got to be really hard on the morale of your people, your nurses, your administrative staff, people who are breaking out of their flow. How are people staying sane right now in the hospital system?
I think we're doing pretty well overall, because our volumes haven't been that high. We see what's going on elsewhere, and there's definitely this eerie thought of, what happens if this hits us and is happening to us? How are we going to handle it? But overall, morale is good. I mean, we are just taking it one step at a time. We are missing some people we're used to having. We're shorter. We have some people that aren't there. And we're more worried at this point about people that aren't working and aren't getting the opportunities they need than we are about what's coming, I think, in some ways, because that's our current reality. And we're sort of taking it very much at that moment, one day at a time. It's all that we can do. I have many colleagues that are working in Detroit and in other areas where it is absolutely heartbreaking. And there's a huge part of us all that wants to go help, but we know we have to stay here and stay present here for in case and perhaps when we are in the same situation.
Understood. Well, good on you for looking out for your folks and for stepping up in this time of crisis. As we wrap up this conversation, is there anything that you want people to do and to know and to maybe even respect about the work that's going on, what they can do to be helpful to your cause?
I guess a couple of things I would say is, if you have any resources that you can add for personal protection, and you're able to donate that and go through the right paths, it's so greatly appreciated, because I think those resources will eventually need more and more help. We've already been overwhelmed by this. And then also really just to stay at home, or mask yourself when you go out if you absolutely have to. Specifically anyone in the 55 plus range, there's no need to leave. There's people out there that'll come and bring you stuff, and there's resources, and take advantage of all of those resources to keep yourself safe.
So on two of those fronts, because I know a lot of folks are eager to volunteer, do you want things like homemade masks, or is that something that wouldn't be worth it for you?
No, homemade masks we're giving to our patients now. So
Okay.
the patients that are a lower suspicion, not a high suspicion for COVID, but are still coming into our scenario, we're using those. So yeah, homemade masks. And a lot of big companies have the N95s, 2-year supply worth. We've gotten big donations from them. It would be mostly, masks and any type of protection from the virus. Even if you're working in like a kitchen and you have a lot of the hair nets and like the type that sort of keep that safe, all that is helpful. Anything that will protect us. Every hospital has its own process to go through to make sure that it's appropriate, but they all help keep us safe and then help keep the community safe.
Brilliant. And I know folks are also interested in delivering meals to the hospitals. Is that something you guys want and appreciate?
Yeah, I mean, everyone's appreciated it. It's been very well received. I feel like we're all going to gain about 10 pounds through COVID. But certainly takes the stress off having to, when you are home and you do have downtime, not having to think about your next 10 meals has been a huge help. And just even the signs people have made or the, the parking lot horns or whatever have all been, I think, very moving, that the community recognizes that we're all doing our best to come together to fight this pandemic.
Well, we recognize that you guys have been busting butt and are on the front lines of a serious effort. And we appreciate you so much. And thank you so much for using some of your precious time to chat with us, Dr. Bonanni.
Thank you. Thank you so much for including me.
Absolutely. Talk to you then.
All right. Take care.
You too. Bye-bye.